Good morning. The learning objective is actually simple to describe the age-associated trend in clinical hypertension, and then we are going to explain the classification. So basically, if I give a case, let's assume that I give a case having older person having certain diseases, for example, diabetes mellitus. I actually want you to know how to classify their BP. I want to know what is the target BP goal for that particular patient that you need to have. And also, I want you to give a treatment regimen. For example, you want to give certain drug in the full regimen. Okay, that is what I want from this lecture. I just want to highlight to you that the prevalence of hypertension in elderly is very high, 71.7%. That is extremely high. More than two-thirds of older people have hypertension. That is very significant for us because two out of three people who are coming to the pharmacy will have hypertension. The most important is about 20% of them, 1/5 of them have pre-hypertension. That means we as a pharmacist have a bigger role because pre-hypertension is something about prevention. So people always say, what a pharmacist can do? We can't prescribe medicine. No, we can still do many things. So this is where treatment of hypertension is very important. So BP is actually the force of the blood on the wall of artery. And the formula for it is very straightforward. Cardiac output times systemic vascular resistance. SVR is systemic vascular resistance. Cardiac output is equivalent to heart rate times stroke volume. So you can see the formula here, BP equals to cardiac output times peripheral resistance, right? How important is pathophysiology? What can increase cardiac output? Contractility. And then you can see here what stress can increase contractility. Obesity can increase contractility. Endothelial dysfunction can increase contractility. So you can see here the red colors are important risk factor for cardiovascular disease, for hypertension. Patients who are having renal impairment, that is what we call fever neurons actually. So basically it's going to cause renal sodium retention. When there is a sodium retention, it's going to increase in the fluid volume. When there is an increase in fluid volume, preload, when your heart is pumping, the preload will increase and this is going to increase the cardiac output. Okay. Definition of BP. Okay, now so you said you already know the Malaysian guideline, right? So we also have something called JNC8. They define blood pressure as systolic more than 140 and diastolic more than 90. Isn't that this is familiar? This is what also in Malaysian guideline, right? The classification of ISH, isolated systolic hypertension. From the name we already know, it's a systolic hypertension. What does it mean? That systolic more than 140, ISH is one of the common types of hypertension in older person. So emergency and urgency, the difference is very simple. Emergency means there is already acute target organ injury. In older people, we also have to know one thing. Orthostatic hypertension is defined as a reduction in the systolic blood pressure of 20 millimeter mercury. In Malaysian guidelines, we have at risk. At risk is something we call pre-hypertension in JNC8, which is less than 140 but is more than 129. These are very important because this is the group where pharmacy should be focusing in a community setting. This is the group of patients you should actually try to treat them and avoid them from having they go into stage 1, 2 and 3. And in Malaysian guideline, we have severe stage 3, which is rarely we see in the international guideline, because in international guideline, they will always say that anything more than 160 as a stage 2. When in more than 180, we call it emergency or urgency depending on the things. This is the JNC8 guideline. You see, I told you earlier, we have this quite very similar. We have pre-hypertension, stage 1, stage 2. That's it. The question is I want to ask is, does elderly hypertensive is actually really specific, have really specific characteristics? We do see certain special characteristics. The sodium sensitivity will increase as we get older. So this is one of the characteristic, age-associated characteristic. What does it mean? If someone is getting older, their sensitivity to sodium will increase, as does hypotensive response to diuretic. This is also very special in older people. That means as people get older, the response, the hypotensive response is higher as compared to younger adults. That is why in any guideline, we don't recommend to give furosemide for reduced blood pressure. The second is, I already covered, isolated systolic hypertension, which is ISH, is more frequent than the systolic diastolic hypertension. Another characteristic which is relevant to the second one is increased arterial stiffness. There is a greater incidence of endothelial dysfunction. In older people, we will see increase in the systolic blood pressure. That is why increase in the ISH. When the systolic is higher, diastolic is lower, this pulse pressure will increase. Left ventricular mass, isn't that as we get older, there will be higher incidence of left ventricular hypertrophy? Why? Because the heart, the left side of the heart have to work harder and harder and harder. It's like going to the gym. If you go to the gym, for all of any of you are going to gym, you know that. If you go to the gym, if you take a dumbbell, every day you take, the muscle will become harder and harder. It will become big. That is what happening to the heart. The heart is working hard. Obviously, the wall thickness will increase. This is normal, right? Arterial stiffness increase and calculated TPR also increase. Total peripheral resistance also will increase. Logic. These are all logic, right? It's all interrelated. You don't even have to memorize all these things. It's just logic. And then obviously, if these are things increase, the opposite, cardiac output will decrease. Heart rate will decrease as we get older. And renal blood flow, renin activity, angiotensin level, all is going to decrease. Everything is going to decrease. Yeah, and the renal blood flow. Remember my distribution lecture on pharmacokinetic focus on the distribution? There is a decrease in the organ blood flow, including renal. Arterial compliance is going to go decrease. When there is this arterial compliance, the relationship is with the arterial stiffness. There is more evidence coming now in the future. We are anticipating maybe in 20 years' time, once they have a machine that can measure the pulse wave velocity, which is measure of arterial compliance, we won't measure blood pressure anymore because this is more accurate. Okay. So when there is an increase in arterial stiffness, the compliance become decrease, and that is can be measured using pulse wave velocity. Okay. Diastolic blood pressure also decrease. That's good. So far, are you guys okay? Are you guys with me? Okay.
Yes, doctor.
Okay,
Yes.
Shakina. Thank you, Shakina and Azhar and Mawani. Yes, Dr. Junhua. Junhua, okay, that's good. So, and also Doreen. Now let us jump into the management of problem in the elderly. So all the changes that I told you earlier, in fact, I already highlighted why could hypertension is also very common in elderly, right? So what we do, we should measure their automated BP recording. So that's why we got ambulatory BP recording, whereby we will ask them to wear the BP measurement and go back home, and we measure the whole day. Okay. Automated BP also can be done at home. For those who have white coat hypertension, we also ask them to measure if they have at home. If not, we will refer them to go to the community pharmacy. At least it's less worried. Hypertension, hypertensive syndrome. So measure postural changes in the blood pressure. So because there is a higher chance of orthostatic hypertension, then we should actually measure their postural changes. So older people, it's not only we ask them to sit and we measure, we will take sitting and standing position as well. Also, inadequate response to the therapy. For older people, most of the time, if they have an inadequate response to therapy, what we should do? We should check their compliance. It's most important because they most of the time they don't take medicine. Okay. I mean, this is so common actually. Older people, I mean, they say, why I want to take all sort of things. Even young people are saying the same thing. Pharmacists is saying the same thing. I'm expecting the same thing. The problem. Perform fast wave velocity. This is in overseas they have, but in Malaysia we don't do this. Okay. If they don't have response to therapy, we want to measure the arterial stiffness, arterial compliance. Okay. So that's why perform fast wave analysis. And then trial of long-acting nitrate or spironolactone. So this is actually more relevant to the spironolactone is given when the patient is having hypertensive resistance. Okay, I will come into that later. Okay, let's go to the next slide. Next slide is treatment goal. So whenever older people have blood pressure, what we should give, what should be the target? As I always say, right, whenever we do anything in our life, there should be a goal. You attend this lecture, is the goal is for you to learn something so that it help you to practice later on as a pharmacist. When we listen to YouTube, we listen, and the goal is to, listen to a song actually. The goal is for us to feel relaxed. So everything has a goal. So when you give a drug, there should be a goal. And to measure the goal, make sure that you learn how to measure the blood pressure accurately. Okay. One of the things usually we assess during the OSCE, right? Okay. You should, okay, you must, not should, you must know how to measure BP. There is no for this actually, because at least the least we should do in the pharmacy. For those who later have opening a pharmacy shop, make it a practice. Make it a practice that whenever your patient come in, measure their BP. So it is a good practice. It's like a medical doctor. Whenever you visit a doctor, they will measure, they take the stethoscope and listen to the heartbeat and everything, right? Do this, right? Because we are entitled to measure the BP, right? Just as a practice. By doing this, you are also increasing the patient interaction as well. But do not talk between the measurement. That is, you don't talk within the measurement. So usually, there are so many things you have to know. Don't cross your leg. Okay, put the feet flat on the floor. Because these are things you have to. That's why in a community pharmacy, it's good to have the chair that is adjustable. Because we will have all sort of people, tall, short people, and everything. So we'll have a adjustable. See, all these small things we have to think. Right? So many things. Huh? I hope by now you know, right? When they come for blood measure, don't you make sure there's bladder is empty. No smoking for the last 30 minutes. And then no coffee as well for the last 30 minutes, because all these are stimulant can increase in the heart rate. Also, when you are too beautiful, makeup and everything also will increase the heart rate as well. Okay, now treatment goal. Let's go to the treatment goal. This is I want to highlight the JN. And now there are going to be activity as well. I want to ask you a question. This is JNC8. Okay, JNC8, where the treatment goal is for patients who are adult patient, less than 80 years old. The systolic blood pressure should be less than 140/90. Now you guys tell me, is it similar in Malaysian guideline or not? The first goal. Treatment goal for adult. I'm not talking about patient with diabetes, patient with CKD and everything. Just a normal treatment goal. Okay, similar. That's good. Anis, Mawani. Okay. Anis said that is similar. That's good. Because Malaysian guidelines taken from JNC8. Okay, and also because obviously when these are taken from the clinical trial as well. So in younger patient less than 60 years old, treatment guideline is 140 and treatment goal is 140/90. Okay, remember, anyone have more than 140, we give them treatment. Okay, and then the goal is to less than 140. The goal is not 120. Remember this. That we call intensive blood pressure reduction. Which is in a sprint trial, we call it. They did measure that and they found that it's a beneficial, but only patient without diabetes. So there's a different thing, not to your level, there's a master level. So in older adults, we have less than 150/90. Very easy to remember. 150, for this 140, this is 150. Okay, is it similar to Malaysian guideline? I will tell you in a while. Okay, and then in JNC8, we have 140/90 for those who have diabetes and CKD. But these are slightly different in the Malaysian guideline. Let's have a look because they make it easy. Okay, so the treatment guideline. This is I took this. You see, it looks different from my slide. I mean the color, right? So I actually copy paste exactly from the Malaysian guideline. So for older people, okay, they define also very elderly. For very elderly, more than 80 years old, the treatment guideline is less than 150. This is, okay, Malaysian guideline. More than 80 years old, which is very old person, we call it. You see, young adult, older adult is more than 60. More than 80 is very old adult. So very old adult, the treatment guideline is less than 150 systolic. For 65 to 80, is less than 140. This is one confusion. Can you see the confusion? Malaysian guideline, you know, they put 65. This is from the clinical trial. But the definition for aging in older people is 60. Sometimes, this is what I say, when you copy paste, don't copy paste properly. Yeah? Okay, 65 to 80 is less than 140. This is different from the JNC 8, which was in JNC 8. JNC 8 they mentioned 150 over 90 for more than 60 years old. Okay, this is 65 less than 140. And for multiple comorbidity, those who are frail, those who have experienced AD and everything, we take a less stringent. So there's one thing. As you can see here, for fit, they can even go even lower. Fit, older people. How do you define fit? The word is fit. Very broad terminology. Okay, fit. Okay, that it means they don't have any comorbid condition, health condition that is actually equivalent to frailty. No comorbid condition, actually they are actually can mobilize. Mobility is higher and can function normally. Mobility or functional ability, and also the cognitive status is normal. If they are this is what we call healthy, fit. In this group, we can go even lower, systolic blood pressure less than 130. But in older people, frail means here is opposite what I told you, the healthy one. Frail is those who are cognitively impaired, those who have dependent of functional ability. Dependent means they can't do the buttoning, they can't eat, they can't take shower, they can't wear their dress. That means dependent of activity of daily living. We call it functional ability is dependent. And those who can't move, limited mobility. This is what we call frail patient. Okay. So in this frail patient, what we should do, we should not go very, very strict. We should a bit relax a bit, maybe 140, less than 140, or sometimes we can also give 150. So if this is just to make you to realize, okay, I just pick up this from the Malaysian guideline. I just list everything in one page to see how different is it. So many things we have to remember. But the most important thing is diabetes is less than 140/80. Because in older people, we tend to see a lot of diabetes cases. But if your patient is having left ventricular hypertrophy, already have LVH, you can be more stringent. 130 over 80 is not under 40, 130 over 80. Okay. This is equivalent also for patients who have lacuna stroke and patient is having renal impairment with proteinuria more than 1 gram more. It's severe cases, under 30 over 80. Others all straightforward. 80 years old or older people, less than 150. And the fit, 65 to 80, less than 130. So now, so many things, right? Just remember the Malaysian guideline and remember this. Whenever people ask you to give a treatment goal, always mention like this. Okay, according to the Malaysian guideline, the patients actually are in the age range of 65 to 80. Is actually systolic blood pressure less than 140 millimeter mercury. Okay. You have to mention like this. If people ask you what is the treatment goal, don't come and a patient who are admitted and then you say the treatment goal is less than 130/40 or 130/80. Sorry. Why? For what? Why you say that? You always cite. It's because according to the Malaysian guideline, it should be the patient is having diabetes. So this is a practice that you have to make from now on. Always cite the guideline that you are using and also the treatment, the reason why you are giving that BP goal. If you don't say that, we will assume it's wrong. This is in the practice, we will assume it's wrong because isn't that American has a different treatment goal, JNC has a different treatment goal, international, these are international body. Malaysian have a different. So a person who are the consultant or a specialist, they did everything. From your perspective, you only read Malaysian guideline. So you assume that everyone knows Malaysian guideline. In their head is only Malaysian. No, you always must cite the thing. Is it clear so far? Okay. What is lacuna stroke? Okay, stroke, Emily. Lacuna stroke is a type of stroke. There are several types of stroke. We have lacuna stroke, whereby there is a changes in the, and then we have vascular stroke. We have hemorrhagic stroke. Okay, the lacuna stroke is happen very commonly in patients who have Parkinson disease or those who have stroke. Secondary stroke is a second type of stroke. It happens more on the left upper quadrant of the brain. That is lacuna stroke. It's a type of stroke. Okay, that is why we make it more stringent actually, because those who have lacuna stroke, they have a higher risk of getting hemorrhagic stroke. Hemorrhagic is the blood vessel is bocor. Okay, when there is a blood vessel bocor, that's why we need to be more stringent. 130/80. All right. Secondary prevention is more common in the second recurrent of stroke. Any question? Emily, did I answer you? I mean, did you understand? Not I answer, but did you understand, Emily? Yes. Okay. Thanks, Emily. Any other questions so far? Hey, you guys should talk. Put yourself. When you are practicing later, you don't practice by computer like this. I noticed that you guys don't even put a picture of yours. So scared of your. Life is not being in behind the screen. Actually, life should be forward, way forward. You talk like this to me. If you avoid yourself, you are not exposing yourself actually, which is not good. Okay. Lim Won Yi, nice name. Doctor, if the patient has multiple clinical conditions, we should use the one with lower BP goal. Yes, true. Won Yi, if the patient has multiple clinical conditions, for example, let's assume a patient who have a renal impairment with diabetes, and also patient is having lacuna stroke. So in this particular case, we go for the lowest, which is 130/80. More stringent, more stringent. Why I'm saying so? When they have multiple clinic, by the way, there is a trap here because this is elderly patients, right? They can have multiple clinic condition, but also you have to see whether they have mobility is good, independent is okay, and whether they are cognitively impaired. These three things I always say. Okay, this is regarding the frailty. Multiple diseases, but if they are frailty, we cannot be very stringent because they will end up with a higher chance of mortality. But in younger adult means, I mean, even in normal patient, not a young adult, sorry. In a non-frail patient, yes, we take the lower BP goal. Okay, Lim, did I answer you? Yes, thanks. Okay, thank you. A similar approach must be done in other patients. Okay, when you do your applied therapeutic cases, also take the lowest, more stringent, we call it. Okay, lower BP means stringent BP. Use scientific way. I mean, this is when we talk to each other like us, we should talk scientifically, more stringent BP goal. How to treat? We will take a break once we cover the non-pharmacological. How to treat hypertension? Okay. So now we know that what is hypertension. We know what causes hypertension. We know actually how the hypertension is. The characteristics are different in older people. Okay. We also briefly have seen what you call how hypertension is going to be can be. Now we are going to see how we can treat the hypertension. Very simple. There are two approaches. Lifestyle modification. Okay, we sometimes we call it LTC, lifestyle changes. TLC, sorry, the lifestyle change, TLC we call it, lifestyle changes. And then another one is pharmacological treatment. Let's jump into before we talk about this, I just want to share this slide. You don't have to remember this, but I want to tell you that, you see, this is the evidence why we should treat older people or any people, I mean, with the diseases. This is a meta-analysis of 68 trials. You see, by reducing blood pressure, okay, reducing blood pressure, systolic blood pressure by 10 millimeter mercury, we are actually reducing the risk of having cardiovascular disease 25%. There's a beauty, you see. There's a beauty of treating patient with hypertension. If you treat a patient for hypertension, we can reduce the mortality of so having heart failure up to 40%. In fact, some of the studies says 50% actually. This is why I'm showing this. So you should know this so that you can tell your patient, okay, when you treat and in the counseling, okay, when you give counseling, it's not that you say, okay, hypertension we should treat. You should say that if I treat you for your hypertension, actually we are reducing the risk of getting cardiovascular disease about 25%. And then they will understand more detail actually. Oh, okay, that is benefit. Okay, rather than saying that okay, you're gonna reduce the mortality, this and that. Okay, in study also have shown that by treating hypertension we can reduce the dementia, but we haven't got an actual reading yet actually. But the but hypertension has been identified as a risk factor for dementia, by the way, especially in an older person. Okay, this slide I want to stop here for us to take a break. This is the reason for us to having any non-communicable diseases. You see, now even you and me also are doing the same mistake. I mean, I'm giving a lecture on hypertension, but I'm also sitting. Obviously, I'm not eating. That's one good thing. But the access to access. This I like this word. That's why I copied this slide from Lambert. Okay, access to access. Too many things. We have so much things. Everything is excessive. Everything comfortable. The chair we sit is comfortable. For those who have a comfortable chair, for those who are sitting on the bed is comfortable. The food is coming to your room if you are at home, and even if you are in let's say in our hostel now, you can pick up the phone, call Food Panda. Everything is excessive. If you have money, everything is excessive. People don't move around all the time. You're sitting, don't even walk to the we don't even go to the television. Last time when we were small, we have to walk to the television and change the channel. Now we don't even do that. Okay. I think this is what is causing the having all this hypertension and everything, especially in Penang. The food, not only in Penang, the Malaysian food itself is dangerous. Okay, so high salt, everything is high. Okay, now let us take a break. Okay, for those who want to stretch yourself, do keto ketampi or whatever it is, do in 5 minutes time we will get back to our to our lecture. Okay, thank you. Let's come back in that thing. For those who want to rest a bit, you can rest now. Okay, lifestyle modification is very important. There are few aspects of lifestyle modification that has already been covered in the Malaysian guideline. In fact, the Malaysian guideline, they have chapter 4, if I'm not mistaken, very detailed about lifestyle modification. I hope you can read that actually, but I'm going to cover very briefly about that. Number one is weight reduction of sodium intake. Number two is sodium intake, reduction of the sodium intake. And then we have the alcohol intake, smoking cessation. Anyone want to say something? Or by the way, can you guys hear me? But I'm talking without. I didn't unmute myself. Can you guys hear me?
Yes, doctor.
Oh, okay, Shafika. Thanks, Shafika. Okay, decrease in alcohol intake and smoking cessation. Increase in physical activity, and if adequate, first-line treatment. Okay. Basically, lifestyle modification is what we should be promoting. This is what we call wellness, and pharmacy has an important role in the wellness. That's why we have the paper on health promotion paper. We teach you how to do health promotion, so that actually you learn how to educate your patients, empower them to understand what is the problem and how to solve it actually. Okay, let's look into the by the way, why non-pharmacological treatment is important. This is a very recent article just published 2 weeks ago, I think. Very recent. They actually you know describe what is the changes of the activity of daily living and how does it increase the blood pressure. I like this, not to remember for you guys to remember, just to show you actually. You see, for just want to highlight one thing, or increase the vascular structure. The increase in arterial stiffness, decrease in the vessel lumen, and increase in resistance. Isn't that this is also happening due to aging? Okay, we know that is happening to the aging. I told you earlier, increase in the vasoconstriction of axis activity. I told you earlier, right? This happening all is because of aging, but in fact, there is now evidence that is also related to the physical exercise, body weight, and everything. That is where we have to do all this. I mean, we have to be active, healthy, so that actually we can prevent the occurrence of the problems. So now it's very clear. It's in one picture. We have all the things over now, the mechanism. So, so it's not simply we ask people to do exercise and everything. Okay, this is the non-pharmacological treatment from the paper, the new paper. I like the picture, so I put. So I already covered, diet with low sodium. Now they're encouraging people to have relaxation technique and also meditations. People having reduced body weight and everything. Let's go very. So a lifestyle modification is important. Now people are asking question, and in fact, the slide I showed you earlier show that it is important. And in fact, there is evidence. This is for you to appreciate. So this evidence, people ask me. I mean, usually people, even my patient used to ask last time when I was practicing in hospital. Now I'm practicing as a lecturer, right? So when people ask me, is it really reducing BP is going to be useful? So I tell you, this is the evidence from the several trial. You can see I've got by reducing just 1 kilogram. Okay, 1 kilogram, we can actually reduce one systolic blood pressure or body weight. Is this useful? By doing exercise 30 to 60 minutes, which is the standard regimen that we tell to our patient, right, we can reduce up to 3 millimeter mercury of systolic blood pressure. The question, I mean, my salt intake, you see, increase sensitivity to sodium, right? Older people, reducing less salt can reduce up to 5 millimeter mercury. The question that is 5 millimeter mercury is significant? Okay, you are pharmacist, right? I'm sure you will ask this question. Is it reducing 5 millimeter mercury is significant? Yes. So evidence also shows that by reducing 5 millimeter mercury, we can reduce up to 14% of stroke. This is only 5 millimeter. That's now the one slide I showed you earlier is up to 10 millimeter mercury. This is 5. So basically, every effort is counted in the preventive medicine. So whatever you do for your patient is going to help the patient. You should understand that as a pharmacist, and also you have to tell to your patient that you are doing for their benefit. And if you don't tell these things to your patient, how would they take the medicine? If I give you a book and say, okay, read the book, you won't read the book. You will only read the book when I tell that story, a brief about the book, and I ask you to read certain chapters specifically, and I tell you why it is important for you. Then you will read. Same thing to the patient. Okay, you have to tell them. Okay, BMI. Okay, let's go. This one, I'm going to go a bit faster because this is a standard exactly the same what we use for young adult for older adult. It's the same. Only thing is when it comes to be older adults, you have to be a bit realistic. You don't ask the patient to reduce 10 kilogram in a month. That is a bit too much in older people. Even in young people, to reduce 5 kilogram per month is a big story. For those of you who are dieting, I'm sure you know, right? To reduce 5 kilo per month is a big task. It's a big task. So we have to be very practical, very practical when we advise people. We go and simply advise people, and tolong reduce, tolong kurangkan berat badan, makcik 10 kilo ya. And then mai tengok bulan depan you tengok 1 kilo pun tak kurang. Okay. So you have to be realistic. Tell in the first month, give them 1 kilo. So once they achieve the 1 kilo, they will, so the psychological thing is, they know, okay, I can do it. If you put a very higher kind of value even in the first appointment, then if you don't achieve, automatically they will say, I cannot reduce body weight. This is psychology, okay? Pharmacists must know the psychology on how to treat the patient. Also for your own self. Okay, you wake up in the morning, you say, it's a nice day, it's going to be useful, I'm going to have a good day. The whole day is good. This you can try. Tomorrow you wake up and you say, it's actually, very cloudy, it's lazy, I want to see Bala face some more. The worst day. Whole day is going to be like that. Okay, it's this psychological thing. Salt intake, advise our patient to reduce salt less than 2 grams of sodium, or this is 2 grams of sodium, because at this age, at this stage, salt is everywhere. So we should actually educate our patient how to read the nutrient behind any of the food product. Maggi mee full of salt. You go and check how many grams of sodium there. Okay, but in terms of salt, is less than 5 grams per day salt in. But this is recommended by WHO lah. Okay, Malaysian guideline also is what is they recommend. Avoidance of alcohol. For your information, for those who are drinking alcohol, the unit of alcohol is, there's a different unit. You can find this in our guideline. One unit is the beer. Beer is less unit. Half a pint is 500 ml. And then we have wine, a bit more stronger, and whiskey is even more stronger actually. Okay, so those who are drinkers, you should know all these things. As exercise, for any exercise, we recommend people to do 30 to 60 minutes 3 times weekly. There is a very strong evidence on this. In older people, make sure they have a brisk walking is enough. Don't ask the older people go and run 10 times round of the stadium, all sort of things. Ini nak kurangkan berat, tekanan darah tinggi, kena lari 1 kilometer. Lari what? Can't even walk few steps. So be practical. So what is we always advise is whatever they can do within their capacity in older people. If they are frail, for frail patient, even by just, because most of the time they're going to lie, right? Because no mobility. Even sitting, waking up and sitting in the chair is a big thing for us. So if you work in hospital later, if let's assume that you got chance working in the geriatric ward, you know what we will do in the stroke ward all? Every day we will have a timetable for the patient to sit in the chair, to sit like this. This is the worst case scenario. Okay, so advise your patient accordingly. Healthy eating, DASH diet. Have you heard about DASH diet, by the way? It's DASH diet which is high in vegetable, low fat, and also reduced saturated, which is opposite Malaysian diet. Okay, opposite Malaysian diet, and opposite of student diet. Even student is even worse. I think if we were student, we were eating all sort of things because we want fast. I remember when I was a student in overseas, we don't have much money at that time. I mean, it's a very hard time. What we do is we cook for 1 week. Still remember this. I don't know how I did that. Saturday, Sunday, cook, pack, 7 packs, put in the fridge. Freezer, take, heat and eat every day 1 food. It's a crazy time. Huh? So how that is a non-healthy. Okay, DASH diet, I mean, for those who are really interested, I mean, you should really know Mediterranean diet, DASH diet is the healthy food actually. Okay. What is a Mediterranean DASH diet? Actually, it's very simple. They encourage you to eat more fiber, and less saturated food. That is the summary I can tell you. Okay? It is important because studies have shown that by taking DASH diet, we can reduce up to what you call 11 systolic, 11 millimeter mercury of systolic blood pressure. Actually, it's a very big amount. A diet can make a change actually. Okay, but the tongue, always wants salt. Okay? So all of you become mother and father one day when you are cooking, reduce salt. Don't keep salt in the table actually. It's a very bad habit. Cessation of smoking. We know that smoking is a risk factor for many cardiovascular diseases. So no smoke, please. If any smoker here, I think you should always, approach to the clinic kesihatan and join the smoking cessation clinic. Sometimes, there is more evidence now coming that giving potassium supplement is good, calcium supplement is good, fish oil can reduce blood pressure, all sort of a supplement. There are two things. There is no strong evidence on that. But if the patient can afford to buy, if they want to try, if that is going to improve their psychological thinking, is going to reduce the blood pressure, you can ask them to buy and take. Because some people, they automatically taking a fish oil, they feel it's more safe than the normal drugs. They feel they have reduction in the blood pressure. You see, what you think, the perception will affect your thought. Okay, the thought will affect the way your habit, the body reaction and everything. So if that is helpful for the patient, please go ahead, ask them to take. As long as there is no interaction with your drug that you are taking. And obviously, fish oil does not have any interaction. Pharmacological treatment, we pharmacists, let's look into. So before you give a drug for older people, there are factors that actually affecting the drug choice. Okay, there are several factors. This is very important. What are the factors? Let's look one by one. Cardiovascular risk profile of the patient. In Malaysian guideline, there is a chart where you can actually risk stratify the patient, whether they have a high risk, low risk, or moderate risk. Okay, I hope you understand what I'm talking. I won't go in detail that, but you can, if those who have a high risk of cardiovascular disease within 10 years, more than 10% of risk of having cardiovascular disease, recurrent of event, then we say they are having high risk. Then we can give we already can start treatment for the patient. Coexisting disorder. Let's assume this now, I think Lim or someone asked me the question. I can't remember who asked me the question. Okay, Lim or someone. So if they have comorbid condition, the goal is the lowest, right? Yes, the goal is the lowest. In fact, the treatment style also will differ. Okay, if my patient is having hypertension with diabetes, then the choice of treatment is ACE inhibitor. If my patient come with already have a cardiovascular disease, then I will give beta blocker, for example. Obviously, they will be on ACE inhibitor as well. Any cardiovascular disease automatic will have an ACE inhibitor. And if I have an older person coming to me, there is a high chance I'm going to give calcium channel blocker or thiazide type diuretic, for example. See, depending on the comorbid condition, if my patient is having renal failure, I can not a dialysis, non-dialysis, I can still give ACE inhibitor. Nothing wrong with that. Okay. So interaction with other drug, also target organ damage. If your patient is having left ventricular hypertrophy, LVH, we should give ACE inhibitor. If your patient is having renal impairment, okay, already have renal impairment, you should avoid the use of furosemide a lot unless you can monitor in detail. See, these are the things you have to be giving. Interaction, always consider interaction because we are talking about older people and tolerability of the drug. For example, your patient is having diabetes, you want to start with ACE inhibitor, but after giving the ACE inhibitor, the patient start having dry cough. not tolerate to the ACE inhibitor, then you can give other drugs, right? You're not going to give ACE inhibitor for your patient. You're going to give calcium channel blocker, for example. Example is amlodipine. You give 2.5 milligram, increase the dose to 5 milligram, and if still not controlled, we can go up to 10 milligram. And obviously, the cost of drug is important. In hospital, we already consider the cost. That is why we seldom see expensive drug in the hospital. But cost is also important for patients who are buying drug in community pharmacy. Don't cut the throat of your patient by giving, if you go to private hospital, admitted, just giving one celecoxib, just celecoxib only. They're charging 200. They think we don't know the price of the drugs actually. These are all, terrible things. Don't do that. So, but anyway, this recommendation table is actually, is very busy because I copy paste from the Malaysian guideline. Starting from page 70, you should start reading the Malaysian guideline. I already put in there my e-learn, right? So let's go through this. Just very important thing I want to highlight here is actually the standing BP and use guide treatment. So if your patient is having orthostatic hypotension, okay, your patient is having orthostatic hypotension, use the standing BP as a guideline, not the sitting one, okay? Sitting one is a higher, but when they stand, there is a 20 millimeter mercury reduction. Use the standing one in older people. It's not the higher, okay, for BP treatment. Assess comprehensively to confirm hypertension. This is for older people. Why? Because older people will have white coat hypertension. They also, another thing we call masked hypertension. White coat is I go to a hospital, my BP is high. Masked hypertension is you come back home, the BP is high. Go to the hospital, BP is low. Come back home, BP is high. This is for older people. Go and see the nurses in the hospital, they feel happy, BP is low. Come back home, see the wife, BP is high. Okay, this is mass hypertension, just joking, that is mass hypertension. So assess for frailty, I told you earlier, mobility, function, cognition. Obviously, nutrition, posture hypertension, and also falls. Older people, we have to assess all these things. Individualized treatment based on clinical scenario, and target BP is actually less than 150 for patient more than 80 years old. I think we covered this. Target BP less than 140 for 65 to 80 years old. Very elderly, less than 150. This is Harvard trial. For those who are like to know about trial, it's HYVET, Harvard. Okay, that's why they follow less than 150. For 65 to 80 years old, is less than 140. For fit, 65 to 80 years old, fit, we can go even more stringent, less than 130. This is a sprint trial. Sprint, SPRINT, sprint trial. Anti-sprint, sprint trial. Let me type. This is for very stringent, and Harvard is for the older person, very old patients. Okay, just this. If you know all these things, it's good for you to know. If you know, you can talk to the people. You can in fact cite the trial rather than citing Malaysian guideline. See, okay, okay. Let's look into the other one. Apply less strict target for frail patient and all the other patients that I told you earlier, and consider prescribing in this patient group. If the patient is a very frail patient, we should consider deprescribing. I think I've already talked about deprescribing, right? So every drug we can stop whenever we need. This is the JNC 7 guideline. I just want to show you, not for you to make you confused, just to tell you that JNC 7, patient more than 60 years old, BP target is less than 150 or 90. You see, already we can give the thiazide type diuretic, calcium channel blocker, or combination. This is the best treatment. Thiazide type diuretic, calcium channel blocker. Let's come to the treatment approach. Let me go through this very seriously. So if your patient have stage 1 hypertension, which is more than 140, 90, we give us observation period 3 to 6 months. Okay, and then we ask them to do what you call the therapeutic lifestyle changes, and we give single drug. First of all, anyone who have a high BP in a pre-hypertensive, all we should give a therapeutic lifestyle changes, TLC. The reduced body weight, reduce all intake. Also, that should be done throughout the thing. And if they still after 2 to 3 months, they still is high, then we can start giving treatment, giving drugs actually. So if they have stage 2 blood pressure, automatically we will start treatment. Okay, we don't wait for therapeutic lifestyle changes all. Okay, by stage 1 in elderly, we do consider them to have therapeutic lifestyle changes. Okay, unless they have a target organ involvement. Target organ means they already have renal failure, or they have hypertrophy, left ventricular hypertrophy, already have retinopathy, all sort of things, then we should treat them immediately. Okay. Follow up, once you give a drug, we can follow up every 2 monthly or 3 monthly. During the COVID time, now I heard they are actually following up every 3 monthly. So whatever time, 2 months is actually best. And newly undiagnosed complicated hypertension, in new patients who are having diabetes without any complication, without any no other diseases, we can give single drug low dose. So the technique in older people is always give low dose and increase the dose slowly. So I took this from the Malaysian guideline as well. You can see for older patient, it's best to give calcium channel blocker or thiazide type diuretic. So it's written here diuretic. Actually, it's supposed not to write diuretic in the bigger. I feel it should be thiazide type diuretic. So even in very elderly, we can give a combination. In fact, the Harvard trial, they give the combination of thiazide type diuretic plus ACE inhibitor. That's what they give. Very low dose. The key is in a stage 2 also, whether it's stage 1, stage 2, you want to give a drug, always give the lower dose in older people. Okay, let's take an example. We're having problem connection. I hope the thing are connected again. Okay, but the phone will not have problem. The phone will not have problem. Okay, so let's assume that you have a patient. This is without concomitant disease. All this is when we have a patient who have diabetes, automatically we are going to give them ACE inhibitor. Okay, so let's say that I have a patient who have a BP 153 millimeter systolic blood pressure, admitted to the ward. Okay, and we diagnose the patient is having diabetes. Now, can anyone tell me what is the first choice of no drug before, never take any antihypertensive agent? Under 59, okay, and then the BP is under 59, already finished the what you call the period of monitoring, giving lifestyle changes already. So what will be the choice you want to give? Patient with diabetes. Can you guys give me the answer? Full. Can anyone give the answer faster? We don't want to waste our time. Are you guys around? ACE inhibitor, that's good. Okay, give me example of ACE inhibitor. One example with a full dose if you can. Michelle, Christina, all answer is correct. Michelle, Livia, perindopril, very good. Visantini, can you give me the dose now? 4 milligram. Okay, that's good. Jimmy and Chinwei, can you go down the what you call reduce the dose a bit? Because we are talking about older people. What is the lowest dose we can give in perindopril? Okay, that's good. 2 milligram. Lina, Doreen, 2 milligram. Okay, so if I have a patient with diabetes, okay, I want to give them 2 milligram perindopril, 2 milligram once daily, okay, and increase the dose gradually. That is what I'm going to do. Every 2 to 3 days, if they are in the water, 2 to 3 days, I can increase the dose to 4 milligram. And the target goal of treatment for older people is what? In diabetes, what is the target goal? Answer. Target goal in your patient, assuming the patient is fit. 140, only 140 or less than 140? That's good, limb. Okay, less than 140 over 80, based on, give me another answer, based on what guideline you are talking about? Malaysian guideline, huh? Okay, Sri Dania, less than 140/80 based on Malaysian guideline. Give a full answer, so don't give a very short answers. Okay, that's good. So thiazide type diuretic plus ACE inhibitor is what we give in a very elderly patient. Can you see here? This is based on the Harvard trial. Combination. Even in elderly patient, you start with thiazide type diuretic and then you can add in ACE inhibitor later. But both will have a low dose. Okay, low dose. That's the key things. Make sure it's low dose and then you increase gradually. And when you increase gradually, it should based on the target goal. If they don't achieve, you can add in another drug. Okay, so this is the standard way of treating older people. First, you give a drug and then you can titrate the dose. Technique, first technique. There are many ways and many techniques. My video is not working. Low bandwidth. Something wrong. Can you guys still listen to me, right? Okay, the first technique is maximize the first dose before you add in second dose. This is if you give a drug, if it is still no control, what we should do. One is maximum the dose, because that's now I told you what, you give 2 milligram, you can still increase to 4 milligram, or you can still increase to 8 milligram, although in elderly we seldom do that, because in elderly we take the second approach. We add in another drug, second drug, because we want to give too low dose. If you give 8 milligram perindopril, the side effect of hyperkalemia will happen. To avoid that, I will give 4 milligram. 4 milligram perindopril, and I add in another drug. For example, I can add in 2.5 milligram amlodipine. Too low dose. Too low dose. This is accomplished trial. Okay, we give too low dose drug to avoid the side effect, but only for those who can't control with the first dose. Okay, in elderly, the technique is very simple. You give low dose, you increase up to the half of the standard dose. So half of the standard dose of perindopril is 4 milligram. If it is still not controlled, it's advisable to add in another drug. Okay, add second drug. Or another way is actually you can start 2 classes separately as a fixed dose combination. Because nowadays we have a tablet, 2-in-1 tablet. Okay, we seldom use this in hospital because it's expensive. Okay, that's another approach. And then you can increase the combination tablet. So if you still didn't achieve the goal, you can reinforce the medication adherence. You give the drug, BP is still high, always check their adherence first before you go and increase your dose, because adherence is the biggest problem. Adherence is the biggest problem actually, so always check the adherence. If strategy A and B, I mean the one I told you earlier, if you already give the strategy A and B means this one, okay, the one I showed you earlier, maximize dose or add in second drug, add and titrate diuretic ACE inhibitor ARB. If still not control, you can also, if you choose strategy C combination, you increase the dose, the one I told you earlier. Okay. If patient is a stage 2 hypertension, combination is recommended. Okay. If already more than 160 millimeter mercury, always give a combination tablet, but in lower dose. So in older people, the best combination you can give is thiazide type diuretic plus ACE inhibitor, or we can give calcium channel blocker plus ACE inhibitor. Okay. If BP is still high, more than 140, already on 3 drugs, then we know that already in one of the 3 drugs is diuretic, we know patient is having resistant hypertension. Okay, 3 drugs, one of the 3 drugs is diuretic, we know patient is having resistant hypertension. In this case, you should give spironolactone. we can add in spironolactone. Okay, but when you give spironolactone, make sure you check the potassium level. It should not be more than 4.5 millimole per liter. The renal function should not be less than 25 ml per minute. 30 ml per minute also we don't give usually because spironolactone does not work there. Alright, how to follow up? You give the drug already. Now you should know how to follow up, isn't that? Follow up is very simple. Patient should return for follow up every monthly. It's a new patient. New patient, but in the ward is different. In the ward, every day we monitor. We monitor 3 times daily in the ward. In fact, those who are having stage 2, we will monitor 7 times daily. BP, very aggressive. We will monitor. But for in a clinic or in a community pharmacy, ask them to go back. Adjust the dose monthly until the BP is reached. Okay, after BP is already stable, we ask them to follow up 3 to 6 months. The one I told you earlier, 3 to 6 months. 3 months is the best. No need to 6 months because 3 months is the best because anything happen in the middle, we can actually check. But it's stable, no other disease. 6 months is okay. More frequent visit for stage 2 hypertension with someone with comorbid condition. See, I told you earlier. Comorbid condition, then more frequent, every 2 months or 3 months. Continue to encourage self blood pressure monitoring. This is where you can do your business selling your own monitoring, but don't sell to the poor people or don't force by poor people. Serum potassium and creatinine monitored 1 to 2 times per year. So renal function, you have to monitor renal function at least once a year. Okay, at least once a year because we want to see any changes in the potassium, changes in the creatinine because all this drug is excreted renally. You know that in older people there is a decrease in the renal function. So I don't want to go into pharmacokinetic lecture again. Okay, that's good. This is the lecture on the hypertensive in the elderly. Okay, I already covered the definition, classification. I have covered the changes in hypertension in older people. What are the considerations in terms of non-pharmacological therapy? I have covered the consideration of pharmacotherapy. Also, we have covered how to monitor the patient. Obviously, monitoring is two-way. Monitor for the efficacy, which is you always see the treatment goal, and for side effect as well, because this is an older patient, we monitor for toxicity, monitor for the side effect. So now, tell me what is the toxicity of the monitoring of toxicity, which is side effect of perindopril. Type in the answer, please. Perindopril. How you monitor perindopril? Monitor for dry cough. That's good. What else? Not only cough. Who is this right? I need to go to my computer. Okay, chai is dry cough. Skin rashes. Monitor for potassium level. That's good. Potassium level. Give Christina and Liu. Can you give me the and also can you give me the normal potassium level? Maybe can talk directly also. I don't mind. Anyone wants to speak also can speak directly. What is the normal range for potassium? Excuse me. Hello. 3.5 to 5 millimole per liter potassium level. Always remember this. So in fact, in older people, we always be careful. We should be careful that more than 4.5, we will be very cautious actually. Because more than 5 millimole per liter, the patient will start having atrial fibrillation. And more than 7 millimole per liter potassium, patient can die of cardiac arrest. Okay, potassium level, don't only mention potassium level. You are USM student, you mention 3.5 to 4.5 millimole per liter or 5 millimole per liter. Any other things you want to monitor? Potassium, dry cough, skin rashes, what else? Very good. So far is good. Hypotension, no Safika, very good. This is in older people. This is what I want. Hypotension, I was expecting that answer. That's good. And Visantini says skin rashes, which is also common in the perindopril. It's less common, by the way. Any other things that you want to monitor, by the way? Dehydration. Santini said dehydration. Okay, accepted. Renal function. Can you give me more detail, Lai? Junhua? One is, what type of renal function you want to monitor? Creatine clearance, very good. Of course, you have to monitor the creatine clearance. Can you give me another example? BUN, blood urea. Okay, that's very good, Lai. Urea. BUN, blood urea, nitrogen. Anyone wants to add in anything? EGFR, okay, Jimmy, that is equivalent to the EGFR is a marker for renal function. Very good. Okay, we have to monitor that so that we can start looking into the drug. For example, ACE inhibitor. We know that ACE inhibitor can cause decrease in the renal function. So we want to be monitoring very carefully. All right. So in diabetic patient, especially where they can have retinopathy. Apa yang for renal? What do you call? What pathy for renal? And they have renal impairment. There's a term for that. I forgot already suddenly blackout. Okay, so that also we have to measure the renal function, especially for diabetic patient as well. Okay, that's good. It's a beautiful picture from Brighton. Okay, this is my study place. Okay, that's good. Any other question, by the way, so far? Any question, guys? Can Dr. Hui Ting ask, can you please repeat when should we give spironolactone? Okay, spironolactone is actually aldosterone antagonist. We should only give spironolactone in a resistant cases, a hypertension resistant. How do we define hypertensive resistant? Patients are already on 3 drugs. Okay, 3 drugs. Assuming that patient is calcium channel blocker, ACE inhibitor, okay, amlodipine, perindopril, and also already on amiloride, for example. So one of the drug must be diuretic, hydrochlorothiazide, amiloride, any types of thiazide type diuretic. Okay, hydrochlorothiazide is the most common we use. Okay, so if the patient already on these three drugs, one of it is thiazide or one of it is a diuretic, then you classify the cases as hypertensive resistant. The option is you can give spironolactone. So patient will be taking 4 drugs? Yes, of course, patient will be 4 drugs in total. This is very common in patient with renal function and in patient who are in a, so those who are, when you do the ward round later, if you go to the medical ward, you go to the renal ward, ward number 8, C8, you will see the patient will be taking 4 drugs. If they cannot, in a dialysis patient, you cannot give spironolactone, by the way, we think, and for the others as well. In patient with dialysis, patient less than 30 ml per minute, spironolactone will not work. I hope you know what is the mechanism of spironolactone. It will not work. In that case, we can give alpha blocker, prazosin. But in older people, we should avoid prazosin as much as we possible. Okay, we think, I hope I answer your question. Any yes, okay, thank you. Any other things? Any other question, by the way? Chin waiting. Okay. Doctor, if patient is taking antihypertensive medicine and BP drop to 160, is it considered hypertension? Yes. In older people, we would not give, we don't want to treat them less than 120 millimeter mercury. I know there's a definition for hypertension, right? But if it is less than 120, we should not treat less than 120. Okay. We don't want to be very aggressive. Why? Because hypertension can cause what you call higher risk for dementia. Hypertension have been shown to cause higher risk for Alzheimer's disease. So please don't treat older patient aggressively. Don't shock. Okay, in this one, because the treatment guidelines says less than 140 over 90. So, even we can treat up to 70 millimeter mercury. Don't do that. Okay. Okay, don't go very low. Very low blood pressure, low perfusion to the body is also harmful for the patient. Okay, that is what I always say. Drug is dangerous. That yesterday I read somewhere the difference between a poison and a drug is actually the dose. It's very nice. Ensure not less than 120, right? Yes. Please ensure it is not less than 120. If it is in a frail patient, on please do less than 120. No, Shafiq, that's good. Okay, Shafika, thanks. Any other question? And even if you have a question later, also you can always email me, ask me as well. I mean, you know about me, I can answer. Okay, thank you very much.